there's quite a few of you have entered our seminar, and quite a few more people are slowly trickling in. So I'd just like to say to everybody who's registered for tonight's seminar, welcome. This is another seminar hosted by Lyme Disease UK. I've had quite a few over this year now, and they've been very successful. And we're really, really pleased to welcome Dr. Gupta to our seminar this evening, and thank you so much for giving up your time for us and everybody who's registered. There's been a huge registration to hear you speak, so we're all really excited about it. Just information for everybody, this session is being recorded, so there's no need to try and write notes or try and write down everything Dr. Gupta says, because you will all, everybody who's registered will get a recording of this session. We do keep everybody's video and microphone switched off throughout the session so as not to distract Dr. Gupta, because it's very distracting when you are talking. And if you could just respect that, that would be really good. There are 3 moderators in the background, and if you have any problems or any technical issues, you can type in the chat box at the bottom of your screen and they'll do their best to help you out. So here we go. A brief introduction to Dr. Gupta. Dr. Gupta qualified in 1995 from Charing Cross Hospital, very familiar with me, Charing Cross, in London, and relocated to Manchester, where he completed a research fellowship in heart failure medicine under the mentorship of Professor Ludwig Nases. He then completed his specialist training in heart Nases. And in 2009 went to the Brigham Women's Hospital in Boston, Massachusetts, to complete a fellowship in cardiac magnetic resonance. After being appointed as a consultant cardiologist at York Hospital in 2010, he has helped to develop cardiac imaging services, including stress echocardiography, transesophageal echocardiography, and cardiac CT. His specialist interests include all aspects of non-invasive cardiology and imaging. Dr. Gupta wants to empower patients to take control of their health by addressing their lifestyles and preventing disease from happening in the first place, the first instance. So there you go, Dr. Gupta. Over to you. Dr. Gupta is going to share a PowerPoint and talk through the PowerPoint, and at the end we'll have some questions that have been pre-submitted, and if we have time we'll take a couple from the chat box. I'm just going to turn my video off and mute myself, Dr. Gupta, but I'm in the background if you need anything.
Lovely. Thank you so much for having me. It's a real privilege to join you all, and I hope that I can share some of my experience with dealing with patients who have this condition, PoTS. So what I'll do is I'll do a presentation first, and then of course I know there are lots of questions, and I always believe that any such interaction between a doctor and a patient should be about the patient, and the patient leads the discussion. So I'll hopefully yield back any remaining time I have for questions. So my slideshow is entitled PoTS, a Remarkable Condition. And I like to refer to PoTS as a remarkable condition because it is truly remarkable for several reasons. It is remarkable in the sense that it tends to affect generally young, previously healthy, and often high-achieving patients, patients who were remarkable even before they became ill. It is remarkable in that it seems to affect so many different systems of the body. It is remarkable in how debilitating it is for the patient, and yet how invisible it is to the outsider. It is remarkable in how prevalent it is, and as yet there is such how little recognition there is for it by the medical profession. And it is remarkable that despite all the advantages in technology, we still don't quite know why it happens and how we go about curing it. Now, let's go through it. So the first description of this condition that we now recognize as PoTS was made in 1871. And this is the surgeon on the left. His name is Da Costa. He was a surgeon in Philadelphia. And what he observed was that when he observed this in soldiers who were participating in the American Civil War. And the typical case was the civilian who had been enlisted into the war and who was sent on long hours of marching. Often these guys would have to do up to 20 miles a day at double quick pace with poor food, poor water, and often in bad weather. And he noticed that these soldiers would then develop a viral infection, a diarrheal illness, and then they would become exhausted, they would fall out of line, and they would then have to go away and recuperate. And then they would come back having recovered from the infection. But when they returned to marching, they would not be able to keep pace with the other soldiers. So consequently, they would have to be rehospitalized. So it seemed that they never really regained their normal level of functioning after this particular illness. And these patients would complain of symptoms like palpitation, breathlessness, fatigue on mild exertion. And what he noticed was that their pulse rate, their heart rate would shoot up, particularly in response to standing or adopting an upright posture. And over the course of the passing years, many doctors have recognized this syndrome of these symptoms and this finding of the pulse rate going up. And they've given it many names. So initially, Da Costa called it Da Costa syndrome. Subsequently, it started getting called anxiety neurosis. Then it was called chronic orthostatic intolerance. Then it was called mitral valve prolapse syndrome. Then it was called positional tachycardia syndrome. And now, finally, it is known as PoTS. Interestingly, it is perhaps still existing under different names. So if you go to a neurologist, a lot of patients who go to neurology where the neurologist does a bunch of tests for this particular condition, but does not find anything particularly wrong, they will bill it as functional neurological disorder, FND. And I have no doubt in my mind that if I go to a neurology clinic and take all the FND patients and I look for PoTS, I will find it in a significant proportion of those patients. Similarly, there is significant overlap with chronic fatigue syndrome, ME. And to my mind, whenever I hear the word chronic fatigue syndrome, ME, I like to look for PoTS because I would say that about 40%, 30 to 40% of patients have criteria for PoTS. Similarly, joint hypermobility syndrome, similarly fibromyalgia, and possibly now even long COVID. And we can talk about that when we take the questions. Now, the current definition of PoTS is an increase in the heart rate of more than 30 beats per minute within 10 minutes of standing from a supine position. So patient is lying down and they sit up or they stand up, their heart rate goes up by more than 30 beats per minute. And it is thought that with children, you would have to hit 40 beats per minute to make that diagnosis. And the tachycardia seems sustained. So rather than it just going up and then coming down, it is required to stay at that level. Interestingly, and this is something that a lot of clinicians who are inexperienced with this condition don't recognize, and that is that the blood pressure does not fall. So a lot of people say, well, your blood pressure did not fall, so you don't have this. Your blood pressure does not fall in PoTS if you stick with the traditional definition. And the other thing, of course, it is a chronic illness, so it isn't a one-off. It is something that you can pick up over a period of months and years if you do the tests again. This is the current definition of PoTS, but the reality to my mind is that in some ways the word or the term PoTS probably does patients who have this condition a disservice, because a lot of clinicians believe that it is a condition of standing up or sitting up. And what I have found, and what everyone else who deals with PoTS has recognized, is that there are a ton of symptoms that patients get even when they're not adopting an upright posture. So it is not just a condition of standing up or sitting up for a prolonged period of time. It is something that is happening in the background all the time. Yes, it gets worse, or it is more dramatic when you sit up or stand up, but most patients with PoTS will complain of brain fog, headaches, nausea, tremulousness, blurred visions. No one wakes up feeling refreshed. They're all tired. They all have gut issues, heartburn, bloating, diarrhea, and constipation, really bad constipation. Things just do not move. They get, the nausea is so bad sometimes, in the worst cases, that patients just do not eat. Urinary symptoms. Now, that's something that a lot of people don't recognize in PoTS, but if you speak to patients who have this thing, whatever this condition should be called, they will often say, I feel like I have a UTI and I'm constantly going, but I can't go. But no one finds a UTI. So I'm constantly, it's almost like I'm constantly needing to go, but there is nothing found when I have the tests. They often have pain. Another thing which is really interesting is a lot of patients will describe not only a heart rate shooting up when they're adopting an upright posture, but even if they have a bloated stomach, or if they've had a big meal, the heart rate goes up. They'll also complain of palpitation, lightheadedness, chest discomfort, breathlessness, and not uncommonly collapses where they actually fall because they've lost consciousness. So when you think about it, it is not just a condition of standing up. And that is why perhaps the word, oh, this is another thing that a lot of patients will describe, a bluish discoloration of the legs, very typically like this. This is known as acrocyanosis. So when you think about it, PoTS just talks about a postural condition, a condition that occurs in response to posture, whereas actually this is a condition that certainly gets worse with posture, but manifests all the time as well. And therefore the definition PoTS, the word PoTS, does not capture all these symptoms. And that is why a better term for patients with PoTS is a dysautonomia. And a dysautonomia refers to an imbalance between the flight and fight responses in the body and the rest and digest responses in the body. And therefore, if you think about it, and if we go back to the symptoms that I described, all these symptoms can broadly be described as either flight or fight symptoms or rest and digest symptoms. So these patients are always in flight and fight mode and rarely in rest and digest mode. So they are, on one hand, tired because they don't rest, and on the other hand, wired because they're constantly in flight and fight mode. They just have too much adrenaline. And a lot of patients will describe that. They will say, I get adrenaline surges, and it is horrible. How common is it? It is far commoner than we realize. If you look at the data, they say there are 3 million patients in the USA. Most of these patients are in perhaps the best years of their life, which is the big tragedy with this condition. It affects young people who have so much to look forward to in their lives, so much to give, and yet they've been struck down by a condition which is invisible to everyone else, and they just feel awful all the time. So ages between 15 to 50, but I would say that I have seen younger patients, patients who are as young as 8 years of age, and I've seen older patients, patients as old as 70 years. Certainly more women seem to be affected compared to men, but we do also see men. And I would say this is an underestimate, because since I've been talking about PoTS and treating PoTS, I now get about 4 to 5 patients a day referred to me with this constellation of symptoms. It's interesting because about 4 years ago, I had 2 or 3 patients with PoTS. And when I would do my clinic, you know, the nurses who helped out in clinic would say, what is this? And now 4 years down the line, at least 4 of those nurses have come to me with exactly the same symptoms and have responded to treatment. So I think PoTS is better thought of as a dysautonomia, which is this imbalance between the flight and fight system. And I would never really make the diagnosis just because someone says, look, I stand up and I don't like it. I would always make the diagnosis when someone says, yeah, I stand up and I don't like it, but you know what? I don't wake up feeling refreshed. I'm always tired. I've got brain fog. I've got gut issues. I've got pain everywhere. My life is miserable. It's been like this for the last 7 years. That person, to my mind, has PoTS, regardless of whether they meet the textbook definition of the heart rate going up. So what I'm trying to get across with this is that it is important for doctors to treat the patient, not the test. The test, the criteria are man-made with a tilt table test, 30 beats per minute. What does that mean? If it's 29, does it suddenly mean that the patient's got something else? So I always base my diagnosis on what the patient tells me. And if the patient is describing all these symptoms, then to my mind, that makes the diagnosis for me. Why does it happen? Undoubtedly, I think that the majority of patients have a genetic vulnerability. So in this slide, it says 1 in 8. I would argue that the majority, the vast majority, have genetic vulnerability. They've had this genetic vulnerability. Then they have an index event which unmasks their genetic vulnerability, and that's when they start manifesting with symptoms. So the genetic vulnerability that I see most commonly is joint hypermobility syndrome, or Ehlers-Danlos syndrome, joint hypermobility variant. So virtually all my young patients, if you ask them, they'll talk about clicking of joints, they'll talk about joint pains, etc. That is their genetic vulnerability. Then something happens. For a lot of people, it's a viral illness of some sort, like glandular fever. It may be COVID for a lot of people, and that's why they're presenting with COVID. But this thing that happens, this index event, will unmask their genetic vulnerability. So other index events include pregnancy, major surgery, trauma of some sort. Some people have described the HPV vaccine that they were given as their trigger, and extreme stress, so bereavement, working really hard, something like that happens. And then what the patient finds is they go down almost like they've got a flu or something like that. And then they never quite recover. So they feel like they've gone down, they think they're going to get better, but they don't get better. And then they amble along with that level of, compromise, but then they find that there are triggers. So patients are up there, then they get this index event, they're down here, and then they have triggers which contribute to how they feel on a day-to-day basis. So triggers include dehydration, heat, alcohol. A lot of patients will describe that when they're having their periods, they're particularly bad. Exercise for some patients, so they'll find that, okay, well, I'm okay, I'm doing okay, but then I went for a 5K run and I've been laid out for the last 2 weeks. And I think it's important to understand that, yes, undoubtedly, PoTS is a condition, or dysautonomia is a condition that affects patients all the time, but there is no doubt that they tend to be worse when they've been standing up for a prolonged period of time. And therefore, we have to ask ourselves, what is it about standing up? What happens to the body when we stand up? Because if we can understand the mechanisms of the changes that happen in the body to allow us to stand up, perhaps we can work out how to help patients with this condition. And I usually use this analogy where you have a bottle with wine in it, and basically the cork, the bit at the top, is your brain, the bottle is your body, and the wine is the blood in your body. And you can imagine that when the bottle is laid on its side, the wine hits the top, so the blood gets to the brain. When you stand the bottle up, then gravity comes into the equation and will pull this wine down, and therefore the brain would become devoid of blood, and we would all collapse. That doesn't happen for 2 reasons. One, our blood vessels in our legs detect this surge of blood which is being sucked down by gravity, and they will squeeze. And then the second thing that happens is our bodies notice this change, and we produce adrenaline, and that adrenaline increases our heart rate to try and get more blood going up to our brain. And that's why people don't collapse, because these 2 reflexes come into action and they keep us standing. Now, in some people, what happens is that they cannot squeeze. And one of the ideas that has been branded is this idea that in patients with joint hypermobility syndrome, you have very lax joints. The same tissue affects our blood vessels. The same tissue is in our blood vessels. So our blood vessels become lax. And when we stand up, these blood vessels cannot tighten up. And therefore, the blood starts coming down to gravity. Our hearts notice this. Lots of adrenaline is produced and the heart rate shoots up. That's one possibility. The other possibility is maybe it's that we do squeeze, but for some reason we overproduce adrenaline. And because we're overproducing adrenaline, actually the heartbeat becomes less effective, because if the heart goes very fast, the heart is not getting enough time to fill with blood to be able to pump blood out. So your heart becomes faster and more inefficient. So those are the possibilities that may explain the pathophysiology of this condition. Now, what evidence do we have? Well, there is evidence that patients with PoTS have a reduced blood volume. So actually the amount of wine in the bottle is less than normal. So that's one possibility. Not only that, but they have a smaller red cells. So the red cell volume is also lower. It's very interesting to say, okay, well, if we have a lower blood volume, or if these patients have a lower blood volume, why doesn't the body just compensate and absorb more blood, absorb more water and make more blood? But actually, in normal people, this is done by something called the RAS system, which is a bunch of hormones which are produced by the kidneys. And these kidneys will then these hormones will then make our kidneys absorb more water. In patients with PoTS, and this is a subgroup of patients who are known as hypovolemic PoTS, they have lower blood volume, they actually don't have as much in the way of hormones. When you measure their renin and angiotensin levels, the amount of hormones they're producing are lower, and therefore they do not compensate and they do not increase their blood volume. And because the red cell volume is lower, they're able to carry less oxygen around. And so these patients are termed as hypovolemic PoTS, i.e. the blood volume is low, and maybe that's the problem. Then there is a category of PoTS called the neuropathic PoTS, in which it is believed that perhaps there is a lack of nerves in our peripheral systems, particularly in the nerves that help the blood vessels constrict. So if you don't have as many nerves, the blood vessels don't detect this, and therefore they cannot constrict. And because they cannot constrict, less blood is coming around, the patient feels dizzy, etc. So these patients are branded as having neuropathic PoTS. And I'm going to try and tell you why these people are not separate groups, but perhaps there's just a big overlap. Then there is a group of patients that are termed as having hyperadrenergic PoTS. In these patients, we actually find that they just produce too much adrenaline. Whenever anything happens where they have to produce adrenaline, they produce too much. And in these patients, actually what will happen is, when you stand up, you're producing adrenaline to get the heart rate up. If you produce too much adrenaline, the blood pressure actually goes up when they stand up rather than going down, which is what is seen in hypovolemic PoTS. And these patients will feel like they have a surge of adrenaline at that time, and they can get very tremulous, anxious, and generally unwell. And in these patients, there is some evidence that they have a problem with something called a norepinephrine transporter. So basically what happens is, when you produce adrenaline, you have receptors which will then clear that adrenaline out of your body, and everything comes down and you sort of normalize again. But in these patients, they found that the receptor that actually clears the adrenaline is deficient, and that's why the adrenaline remains in the system for much longer. Another interesting thing that has been linked with patients who have PoTS is mast cell activation. So what they say there is that mast cells are very interesting in that if I take a sharp pen and draw it across my skin will, over a period of time, become red, it'll become swollen, it'll become indurated, and that is a function of mast cells. So mast cells will produce histamine, and histamine will make our blood vessels leaky, And that will allow our white cells to come and try and fight whatever is insulting my skin. And that is the mechanism. Now, in some patients, what happens is they produce a ton of mast cells in response to some kind of trigger. That could be a certain fragrance, a certain food, exercise, anything like that. And so they produce a ton of mast cells, and all their blood vessels become leaky. And because their blood vessels become leaky, suddenly they drop their blood pressure, their heart rate, their blood volume goes down. And consequently, as a consequence of that, their heart rate goes up to try and compensate. And these patients are termed up as having mast cell activation. And there's a lot of interest in mast cell activation. And certainly in my practice, if I get anyone with PoTS, I do send them to a mast cell activation expert to look at. And in my experience, what I found is that they would give these patients empirical antihistamines because that's the treatment. And some people find that that has helped, but I've never really found anyone who has been transformed. One of the other things which is interesting is that the tests that they do for mast cell activation are very expensive tests. And I'm not sure, I sort of am a little bit doubtful as to whether mast cell activation just explains everything or not. But certainly I have an open mind and I would send my patients to this. Now, in the old, certainly at the moment, some people think, okay, well, I have hyperadrenergic PoTS, or I have hypovolemic PoTS, or I have neuropathic PoTS, or how do I find out which one I have? And to my mind, I think what has happened is because patients with PoTS, they're always looking for someone to be interested in them. Some ended up with a neurologist, and neurologists did their tests and found, oh, these patients have less nerve supply to their blood vessels. So they branded them as having neuropathic PoTS. And some turned up to a cardiologist, and cardiologists are interested in adrenaline, and they termed them as hyperadrenergic PoTS. I think there's a considerable overlap, and it may well be that all these patients have all these abnormalities. It's just who has done the research and published. And I'm not convinced that trying to differentiate between the different subgroups really makes a huge difference to how you treat the patient. So I treat all my patients in the same way, and many of them respond well to treatment. Of course, there's another element to PoTS, which is that not only can physical deconditioning cause symptoms of PoTS, particularly the tachycardia when you stand up, the inability to stand up for a prolonged period of time, but PoTS itself can cause physical deconditioning. And this was an interesting paper where they took a bunch of patients who had PoTS, and they found that because of the physical deconditioning, the heart size had shrunk in these patients. So the heart was 16% smaller in these patients compared to healthy sedentary controls. And actually, if you then get these patients conditioned, then actually the heart will grow in size. But having a small heart will contribute in a big way to the orthostatic intolerance because the heart is simply not able to pump out as much blood. So physical deconditioning is a really important part of PoTS, both as a possible precursor, but more importantly, as a consequence of PoTS. And that is something that one has to avoid at all costs. Now there is a real interest in this idea that maybe PoTS is an autoimmune condition. Maybe we produce antibodies to the virus that is our index event, and maybe that virus then starts attacking us and harming us in some way. And that's another theory. And the reason that becomes interesting is because some doctors are trialing immunoglobulins, etc. What I have found in my experience is, again, especially from patients who've had COVID, these patients who come in with long COVID, when you ask them, were you completely normal before you had COVID? The majority will say, no, I still had some stuff going on, but I just thought that was me. But now it's so much worse. So I'm not sure whether it's all about a virus. I definitely think that there is this idea of a genetic vulnerability, and then something comes along. And maybe that is an autoimmune phenomena, but there's too much coincidence there with so many people having joint hypermobility syndrome. As I say, people like to classify PoTS in different groups: neuropathic, hyperadrenergic, developmental, but they're probably a big overlap between the different subtypes. In terms of investigating patients, I think it's really, really important from my perspective to emphasize the fact that I like to diagnose PoTS when the patient has been fully worked up and you have not missed anything else. And the reason is that someone like me, to a man with a hammer, everything is a nail, because I see so much PoTS. I'm at risk of overdiagnosing it. So I always like it when patients come and they've gone through that journey where they've been evaluated by a cardiologist and a neurologist, etc., and nothing else has been found. For a lot of people, they say, well, that journey has been a wasted journey because no one found anything. But to me, as their doctor, it is reassuring to know that there was no organic other problem going on which could explain why that patient felt, because you may potentially miss something which could be A, dangerous, B, treatable. So I would always check their bloods, make sure they're not anemic. Anemia could contribute in this way. I would make sure their thyroid function tests were okay, because hyperactive thyroid can cause the heart rate to go up, etc. I would check their electrolytes. I would make sure that their B12, folate, iron levels, ferritin levels are all checked. Virtually all patients with PoTS have vitamin D deficiency, so it's not uncommon at all to find patients with vitamin D deficiency. Does correcting the vitamin D deficiency make the PoTS better? I haven't come across that. I haven't seen anyone saying, oh, since my vitamin D was corrected, my PoTS has gone away. There is a link with things like Sjögren's syndrome, etc. So autoantibodies are important. And serum tryptase is something a lot of immunologists recommend for mast cell activation syndrome. But if you speak to the mast cell activation gurus, they say serum tryptase is a waste of time. And sometimes I think once in a blue moon, you will come across patients who have a adrenaline secreting tumor. And that can manifest like this because, to all intents and purposes, this is a condition of adrenaline excess. But if you had that tumor, then you could remove the tumor and they would get better. And so you could get an idea of that by measuring the catecholamines, the adrenaline levels in the urine. And I think it's important when people complain of fast heart rates, heart palpitations, that you do some kind of monitoring to make sure they're not getting a heart rhythm disturbance here. In PoTS, what you would generally see is you would get the heart rate go up gradually, but sometimes people can have a heart rhythm disturbance, which is generally not dangerous, where the heart goes up suddenly. So this is the hallmark where there's the sudden change, like a light switch, and the heart goes very fast. This is an SVT. And the nice thing is, if you can pick this up, this is a curable problem with an ablation, a simple 1-hour procedure, and the patient will never have this. SVTs can coexist with PoTS. So you can see SVTs, but they may also occur in patients who have PoTS because of the adrenaline as a trigger for the SVT. How do you make the diagnosis? Well, personally, I make the diagnosis on what the patient tells me. If they sound like they have PoTS and they've been tested and no one else has found anything, then I treat them as PoTS. Most people think that the tilt table test is a way of diagnosing PoTS. A tilt table test can help confirm the diagnosis. It does not, however, exclude the diagnosis. And what you would expect in a tilt test is that the patient is passively tilted upwards. And you would generally find in a healthy person here that the heart rate just may go up a little bit, but doesn't really shoot up very much, and the blood pressure remains okay. In PoTS, you would see that the heart rate does go up and stays there until the patient is tilted down and the blood pressure remains stable. The problem with the tilt table test, there are many problems with the tilt table test. The most important thing to understand is that patients with PoTS their symptoms are not always present. Their symptoms can vary. They can vary with the time of their day. They can vary as to whether the patient is having their periods. They may be worse then. Medications may affect the diagnostic accuracy of the tilt test. And the most important thing is that when a condition is defined by a test, you have to know how good the test is first. And so no one has really done that study. So no one has told us that actually, if I take 100 people who sound like they have PoTS and I send them for a tilt test, and then I divide them into those people who have a tilt test confirmatory of PoTS and those who have a negative tilt test, and I treat them both in the same way, then those people who had a positive tilt test all respond to treatment, and those people who had a negative tilt test don't respond to treatment. That's what you need. You need that kind of data to say this is how good a tilt test is. Unfortunately, we do not have data. And in my experience, what I do is I just treat all patients. If they sound like it, regardless of what the tilt shows, I give them a course of medications to see how they respond. And I would say 50% of my patients who respond to treatment for PoTS have had a negative tilt test. So again, for the inexperienced clinician, I would like to stress, do not just base it on the tilt test, go by the patient, be patient-led, not test-led. And as I said, this slide just recounts the advantages and disadvantages. I do a tilt test to validate the patient. If the test is positive, that validates the patient. That patient who has been struggling trying to convince people that they have something wrong. Now they have a test which confirms the diagnosis. So well worth doing. But if the test is negative, that does not dissuade me from treating patients. It needs to be done in an experienced unit. A tilt test is inherently very uncomfortable for the patient because it brings their symptoms on. And because it's passive, where the patient does not really have any control, it's very uncomfortable because the symptoms can be very florid. Medications may lower the yield. It should be done in the morning. And sometimes patients just have a good day. And unfortunately, it is not deemed safe in pregnant women. And unfortunately, one of the groups that are really suffering with PoTS, who there's very little care for, are pediatric patients. And not many places do pediatric tilts because you have to have pediatric resuscitation facilities, etc. Now, how do we manage it? I would say the aims are increase the amount of blood volume within the body and reduce the heart rate. Fill that bottle up with as much wine and reduce the heart rate with the aid of medications if you can. Minimize pooling of blood in the legs, okay? And that can be done by increasing the strength of the leg muscles. Definitely prevent further deconditioning wherever possible. Minimize those adrenaline surges and correct any electrolyte, nutritional, and hormonal deficiencies. And the way I practice my, how I treat my patients with PoTS is, I think there are 4 pillars to the management. And those 4 pillars should all be instituted together. And those include lifestyle. So I think, you want to first and foremost develop a relationship with the patient. You have to let the patient know that you're on their side and you believe them, because the truth is they are suffering. And I've seen enough PoTS to understand exactly how they're suffering. And all these patients say exactly the same thing. So there is absolutely, the question of disbelieving the patient does not arise. And this is one of the biggest challenges for PoTS patients, just trying to get someone to believe them. So I think once you've developed that relationship, then to try and educate the patient on lifestyle management. Again, all lifestyle management is about increasing the amount of blood volume, doing those 5 things that I've listed on the top of the slide. Then medications. And again, I don't think I have anyone who has just improved with lifestyle alone. I tend to be very keen to prescribe medications early because I think patients have suffered long enough, and it just doesn't work where you say, oh, go and do this. Most of these patients are educated people, they're proactive people, they try their hardest and they still feel rubbish all the time. So I'm very keen to give them medications as an adjunct to lifestyle. And I would generally always refer them to a physiotherapist, and a physiotherapist they can engage with on a regular basis rather than once every 6 months. And a physiotherapist who has an interest in joint hypermobility syndrome, etc., because conventional physiotherapists who don't understand this may push the patient too hard and actually may retard their progress. And finally, and this is something I feel very strongly about, and that is patient advocacy. When you develop a good relationship with a doctor who believes you, who wants to get you better, that doctor should be your advocate. He should be there standing beside you and saying to your school and your employer that, hang on, this person is troubled. They really have a problem, and you need to be sympathetic to that. And I think that makes a huge difference for the patient. So if you meet a lot of children who have school and who have the prospect of doing GCSEs, they're just terrified because they think, well, look, I can work really hard. I can try and do everything, even by putting my health at stake. But what do I do if I have a period of brain fog on the day of the exam? How am I going to show? How am I going to cope? And that is hugely anxiety provoking for these patients. So, as part of my advocacy, I would write to their school. I would say, look, this is what can happen. This is not going to be a true measure of how hard this patient has worked or how intelligent they are. Maybe you need to incorporate coursework-based assessments, etc. So, right now, the next thing is lifestyle management. Well, I think it's important to educate the patient. It's important to identify and withdraw exacerbating medications. And one of the most important medications, I think, which exacerbates things are SNRIs, so venlafaxine, duloxetine, those kind of medications. So a lot of these patients, unfortunately, end up, because they're going from pillar to post, trying to get a diagnosis. They're often told they have anxiety. They're often put on medications for anxiety. And some of those medications, SNRIs, can exacerbate the condition because SNRIs stop adrenaline from being taken out of the body. And of course, this is a condition of adrenaline excess. Diet is hugely important, and I'll go through all this one at a time. Compression stocking, sleep management, stress and pain management, and exercise. I'll quickly go through this. I think it's important for patients to realize it is not a dangerous condition. Out of my 600 patients, no one has come to harm. But sure, it is a hugely debilitating condition. It renders the patient's quality of life anemic. It is a chronic illness. It should be managed by a specialist in a multidisciplinary, holistic setting. It requires intensive interaction with the physician, and most patients do improve over time, but never in a straight line. They zig and they zag and they go a little bit forwards, but it's never a straight line. And it's important that patients should recognize their own triggers and avoid them. And I would always try and educate their workplace, their school, etc. As I said, there are medications that can exacerbate PoTS. SNRIs are the worst. Monoamine oxidase inhibitors can sometimes. Antipsychotics, anti-anxiolytics. A lot of patients, the patients with hyper-PoTS, where the blood pressure goes up, get put on blood pressure lowering medications, which will actually make the thing worse. So again, I try and take those away if possible. And also stimulants like coffee and nicotine never help. In terms of dietetics, I tell them to increase their fluid intake to at least 3 liters a day. They require 10 to 12 grams of salt a day, which is 2 teaspoonfuls of salt, extra salt a day. Sometimes that can be quite unpalatable, so we prescribe them slow salt tablets. Each tablet is 600 milligrams, so most times we give them 10 tablets a day. It's good to supplement with electrolytes, something like diaryte. And generally, I would recommend to them that they drink their electrolytes and salt and water even before they get out of bed in the morning. Magnesium can be very helpful. It gives them a feeling of being rested. It helps sleep. I would correct any nutritional or vitamin deficiencies. And of course, I tell them to avoid soda, etc. Compression is very important because it's reducing the pooling. It's helping blood to be pushed back to the heart, but you want the compression to extend as high as possible and ideally waist high. And it should, you are really looking for compression stockings which are Ral's class 2 or Ral's class 3, and they should exert about 30 to 40 millimeters of mercury of inward pressure. And the best place to get measured is a lymphedema clinic, because your GP will struggle to measure you out. Sleep is hugely important. Virtually all patients with PoTS have disturbed sleep, which then contributes to their fatigue. There has been some really interesting data suggesting that the sleep disturbance is due to adrenaline surges. So, for example, I go to sleep, the blue light on my phone goes up. That'll produce a little bit of adrenaline in me, not enough to make me get up or anything like that. But in a patient with PoTS, you produce 10 times more adrenaline, and actually the patient may get up. Now, he may not know he's woken up, then he goes to bed, then a dog barks, the patient wakes up, then it goes to bed. So they can sleep for 10 hours, but when you wake up, you feel like you've not slept at all. So sleep hygiene, avoidance of blue lights, I think nightly rituals. I would definitely recommend that patients with PoTS don't speak to a friend last thing before they go to bed. If they get into an argument, well, that's enough adrenaline to keep them going all night, So very important. Sleeping tablets are generally not recommended because the problem in patients with PoTS is not going to sleep. It is staying asleep. So it is sort of maintaining good quality sleep, and lots of sleeping tablets just help you go to sleep. There is some evidence that beta blockers can help. So if you give beta blockers at night, that will combat any adrenaline surges and people feel that they sleep a bit better. And some people say it's a good idea to sleep slightly tilted, because when you're sleeping tilted, you're actually not, because you're sleeping tilted, more blood is going to your legs when you're sleeping. So that has two roles. One, your leg muscle will be working at night. Two, less blood is going to your kidneys because some blood is going to your legs, and therefore kidneys produce less urine, which means you'll be less dehydrated first thing in the morning. Stress and pain management, this is a vicious cycle: lack of sleep, fatigue, depression, pain. And it's important, again, to act on every component of this cycle. And I think it's very important to understand that a lot of people do experience pain, and they will take painkillers during the daytime, but they don't take painkillers at night because they think they're sleeping. Well, the pain will disturb your sleep. Next morning, you will feel more fatigued and your pain will be worse. And of course, along with all this comes stress. A lot of patients find it very difficult to get anyone to believe them. Family members don't necessarily believe them. And that contributes to a huge amount of stress, and that makes everything worse. And therefore, it's important for patients to work with their employers to modify working schedules. Psychological support and family support is so important. And I'm very open for my patients to embrace holistic alternative therapies, acupuncture, yoga, Pilates, etc. Exercise certainly in PoTS should be encouraged because it avoids deconditioning, but it has to be done gradually. So a lot of what happens is a patient with PoTS will feel a bit rubbish, then they'll feel a bit better, then they'll think, okay, I'm going to get exercise, then they'll go for a 5K run, and they'll be knocked out for 2 weeks. Much better to do a little bit every day and gradually build up, because that way you're avoiding deconditioning, and that's the most important thing. And so there is a protocol called the Levine Protocol, which has been shown to be very beneficial. I think I have a couple of slides on this. I think it's important that patients exercise at least 3 times a week, and ideally for about 30 minutes. And the benefits can persist even after 3 months, but the patients have to continue at some level, otherwise the benefits can disappear. This is the Levine Protocol, where they put patients through this 3-month program, and as you can see, the heart rate doesn't go up as much once they've been on this program compared to if they haven't been. And when you ask patients before training, this was their physical component score. After training, it goes up quite a lot. And similarly, a social functioning score goes up markedly with training. So the Levine Protocol is a good protocol in that sense because it has this evidence base. Another thing it does is the blood volume goes up as you get more conditions. So the more exercise you do, the blood volume goes up, the heart gets bigger again. And that therefore makes for the heart, because it's bigger, it will fill with more blood. Because it's filling with more blood, it has to beat less fast to achieve the same outcome. Now, this is the thing that I think a PoTS doctor can really help you with, which is medications. And in terms of medications, there are really generally two types. There are medications that increase your blood volume, so increase the amount of wine in that bottle. Those include fludrocortisone, desmopressin, erythropoietin. And then there are medications that lower the heart rate, beta blockers, Braden. And there are some other medications that I'd like to quickly talk about. So fludrocortisone is a aldosterone analog. It helps increase the amount of sodium and water we retain. It's generally well tolerated, and it started at a dose of 50 micrograms daily and can be increased to 200 micrograms daily. One of the big problems for patients with this particular medication is because of the fluid retention, they worry about putting on weight. And because of that, a lot of people don't like taking it. But I would say 50% of my patients maybe have benefited from it. Desmopressin, this is a really interesting agent. This is a nasal spray. At least I prescribe it as a nasal spray. Desmopressin used to be given to bedwetters. And the idea was that if you squirt this in the nose, then they don't wet the bed because they keep the fluid in them. Now, the problem with desmopressin is that because it's so good at making you retain fluid, a lot of patients are already drinking a lot. And if you actually give them medication like this, there is a risk if you give too much of it that their sodium levels can drop. So at the moment, the recommendation is that this be used as a pill in the pocket once every week or so. It's a special occasion agent. It's something like, if you've got a wedding to go to and you're worried that you're not going to be able to stand for a very long time, taking this may give you the get up and go you need to attend that wedding for 4 to 6 hours. So in that sense, it's a helpful agent. I would say I've been a little bit disappointed by how beneficial it is. Most of my patients say, yes, it does help, but not as much as I thought it would. But I give it, at least I would say out of my 600, I would say about 30 or 40 said it has been life-changing for them. So worth trying for sure. And there is some data, again, the data is very small, low-level data, but it does reduce the tachycardia and improve symptoms. The good news is it's been given in children as well. The desmopressin used to be used for bedwetters, so there's no reason on why we can't use it. And as a special occasion, pill in the pocket, I think it's great. Then there is erythropoietin. Erythropoietin is a hormone basically that increases blood cell production in the body. It improves blood cell volume. It actually constricts the blood vessels. But unfortunately, it's very costly. It has to be given subcutaneously. And there is a risk by increasing the blood volume that you can increase the risk of blood clots. So I have never used it, and I don't at this point in time intend to use it. Because the last thing you want to do is to take a non-dangerous condition and put the patient in danger. Beta blockers, this seems to be the go-to for a lot of GPs because of the heart rate going up. They would prescribe propranolol, and propranolol does help reduce the heart rate. It may improve symptoms. Unfortunately, propranolol is a short-acting agent and has to be given 4 times a day at the very least for patients to notice the benefit. Unfortunately, it also has side effects. It can cause fatigue. Patients with PoTS are already fatigued. That's the last thing they need. And it can drop their blood pressure. And patients with PoTS often are just holding on to their blood pressure. So when you give them propranolol, blood pressure drops and they don't like it at all. So a much better agent, and there have been some studies comparing exercise training with propranolol, and what you find is that exercise training does not only help the heart rate, but improves physical and social functioning scores. But with propranolol, you don't see this improvement that you see with exercise training. I like Braden, which is another heart rate lowering agent, but it is a pure heart rate lowering agent and therefore does not affect the blood pressure. Much better tolerated than beta blockers. And I would say it is my go-to agent in PoTS. And I would say about 70 to 80% of patients who take this come back and say, I feel better, thank you. The only real problem I've come across with it is that it can cause phosphenes, where it can increase the experience of seeing light. But this is a reversible side effect. Unfortunately, we cannot use it in pregnancy, and unfortunately, we don't use it in patients who take SNRIs, but those patients shouldn't be on SNRIs anyway. And there are some small studies, case reports, little studies suggesting that Iverbraden does help. But I have no doubt, having such a big patient base, that Iverbraden makes a big difference. The next thing, okay, another thing, IV saline infusion. I think that's a really interesting question. The one thing that I found that really makes a difference for patients is intravenous saline. If you can take a patient who has PoTS, who is really struggling, and you give them intravenous saline, they feel better, and they almost describe a miracle. They say, it's like a cloud has been lifted off me. So IV saline does work. The problem is it doesn't work for very long. So it'll only work for about 18 to 24 hours, and then the patient goes back to where they are. Now, the question then is, okay, if it works so well, can you not give IV saline to patients regularly? And that's a very reasonable question. The problem is, one, that there are no real mechanisms in place within the NHS structure to allow for that, because it requires the patient to come in. They have to be somewhere where they can be observed. They'd have to have a cannula to put this saline through. The saline takes 4-6 hours to go through. And so that's a problem. There is no real funding for that. The second problem is, of course, that you can only give so much IV saline through cannulae before the veins start disappearing. So that is a big problem. The third problem is there is no real exit strategy. So the patient feels better, but then they feel worse again. So then they come back to get the fluid, then they feel better, then they feel worse again. So a lot of NHS institutions are reluctant because they say, well, where does this lead us? Where does this go then? And the answer is, for some people, it doesn't lead you to a destination. It just makes the journey more bearable. And so this is a big problem. The alternative is saline infusion pumps, and these are being used in places like America, where people can have a central port, a line into a big vessel, and they can just give themselves fluid by attaching their saline to this line. The problem with a central line like this is that there is a significantly higher risk of blood clots in those patients, and because of that, it is not recommended, certainly not in this country, and certainly not anywhere as such, because of the risk associated with that. Again, the last thing you want to do is take a patient. I completely understand the quality of life matters, but you want to improve their quality of life without risking their length of life, without exposing them to harm. So IV saline works, but how we go about giving it to patients, and because there's no exit strategy, where does it lead to? Those are things that one needs to address. But there are studies which have shown that it does make a difference. There are other medications. One of them is Clonidine. This is a medication that is beneficial because it reduces adrenaline surges, but unfortunately, it's not generally as well tolerated in certain patients, and patients can be extremely sensitive, so we don't really use it. There's another one called methyl dopa. Again, I don't use it. Midodrine, this is a really interesting medication, and this I do use, and it's very good. Midodrine makes your blood vessels less stretchy, and therefore, when patients stand up, their blood vessels do not stretch as much, and therefore they stand up for longer. Again, it has to be given 3 times a day, and one of the 2 big problems with it is that it can actually be very helpful when you're standing up, but if you go to sleep with it, it can actually push your blood pressure up. So it is generally recommended that patients don't go to sleep with it for at least 4 hours. So you shouldn't take it for 4 hours before you plan to go to sleep. And it can also cause urinary retention. But I would say 70% of my patients benefit from Midodrine. Another really interesting medication is Mestinon. This is a rest and digest enhancer. So it increases the rest and digest hormones. Very well tolerated, wonderful agent, helps about 60 to 70%, but for many people, it's a game changer. One of the things it really does very well is it increases gastric motility. And a lot of patients with PoTS will find that they're constantly constipated, they're nauseous, they're always bloated. And this is wonderful in that sense. Other medications, droxidopa, I've never used it. Modafinil is an interesting agent. This is a psychostimulant. It is very good for brain fog. So most stimulants would help brain fog, but unfortunately they may increase the heart rate, etc. But the research with modafinil indicates that it doesn't. So it may improve PoTS-associated cognitive symptoms. So in conclusion, I think most patients require medical therapy in addition to lifestyle modifications. 70 to 80% of patients improve and return to an acceptable level of functioning. Unfortunately, it has to be said that PoTS patients have been and continue to be neglected by the medical profession. And I think raising awareness and for patients to become empowered so that they can go and actually not refuse to be fobbed off is so important. So raising awareness, working in partnership with healthcare providers will improve understanding and hopefully make more treatments available. So thank you so much. I will now yield back the rest of my time to you. And if you have any questions, I'd be very happy to take them.
If you could just stop your screen sharing, that would be great. And then I'll come back. I am back. Yeah, I am back. Thank you very much. That was really, really interesting. Yeah, we can see you. I can hear you. Thank you. That was really, really interesting. And I know that there's lots of people viewing, like myself, who have experienced either mild PoTS or quite severe PoTS. And it's really interesting to hear, you know, your extensive knowledge on the subject. It's really interesting for me. I picked up a few things that I was like, aha. I'm sure other people did. We've actually used our hour, but if you're happy, Dr. Gupta, we'll do a 10-minute Q&A. That's okay. I had a lot of general questions for you, but you've actually answered most of them. So, in fact, I've been through my whole list, and all the general ones I've waited, and there were the answers. So there are a few sent in that were individual questions. So maybe we should look at those. And obviously, from our point of view, Lyme Disease UK, have you come across other patients with a Lyme infection that's caused the development of PoTS? And if so, is treating the infection, does that treat the PoTS, or is it, you know, a bit of a circle?
Yeah, I think I have. There's no doubt about it, because patients who have this, you know, they go on to these, they try everything. They want to get an answer, and so I have come across many patients who have sought out a diagnosis of Lyme and who have started treatment. What I've found is that whilst they've received treatment and their subjective reports are that they have felt better as a consequence, their PoTS symptoms haven't all just gone away.
No.
So the question that arises in my mind, is it the Lyme disease that has again unmasked a genetic vulnerability, and that is why the PoTS is still there? Or is it all about Lyme disease? And 2 years ago, I met up with Professor Jack Lambert, who is a Lyme expert and members will know about him. He said, you know, any unexplained condition is just a virus waiting to be discovered, or a infection waiting to be discovered. Some patients, chronic Lyme, have symptoms which are indistinguishable from PoTS, and he believes in them for a prolonged period of time. So again, I would always encourage patients to seek out an expert, because whenever I've tried to do it, I've found that the medical profession have a very unusual and sort of odd attitude to Lyme. You know, people don't want to talk about it. People are very wary of talking about it, and I find that crazy. And I spoke to a few GPs who had an interest in Lyme, and I said, look, you know, why don't we do a video? Let's get some information out. Let's talk. Let's get information out. People need information. What can we do? Who's interested? And so you have to be very careful. You have to be very careful. And I could never quite understand it. So I'm committed. I'm going to do it. I'm going to try and get people who have an interest in Lyme, and I'm going to talk about it. And you know, the fraternity can, they just have to deal with that, because to my mind, the mark of a civilized society is that you should always be allowed to ask questions, and those questions should be answered through good scientific experiments. You know, it's not appropriate for people to say, oh, well, no, you're not allowed to talk about that.
Yeah, I mean, it is completely crazy in the bigger picture, isn't it? And I'm sure that that would be very good news to a lot of people listening if you do that in the future. I absolutely know that doctors like Professor Lambert would collaborate with you, definitely. So there are a few questions that were sent in that's a bit more specific. So you've got, is it my end or your end? There's a bit of interference. I don't know if anybody else is getting it.
Yeah, I'm getting.
Yeah, I'm getting a bit as well. I'm not sure. I'm not sure. Anyway, it's cleared. Oh yeah.
Yeah, I think I keep getting Jane's webcam on, so maybe. Oh, it's Jane. Yeah.
Okay.
Jane's trying to sort it out.
Okay. So some of the more individual questions, you've answered one, because one was sent in about, do you envisage that NICE would ever use IV fluids? And obviously you answered that.
Yeah, I think the IV fluids is important, because, you know, to my mind, whilst my big problem is I cannot wait for NICE to start endorsing things. These are patients whose lives are passing them by. Absolutely. I can't wait for somebody, experts, to get together in 20 years and suddenly say, oh, now we acknowledge it. Come on, let's, you know, patients are here. These patients are struggling. A good doctor has to be able to wander out of his comfort zone for the sake of his patient. So personally, I say, well, look, you know, these patients are struggling and something makes them better. I know there's no exit strategy, but hang on, my commitment lies to this person who is sort of struggling now. So if I can get them better now, I'm doing something for them, rather than just saying, oh, we'll wait. Well, that doesn't serve anyone's purpose, to my mind. So I have started giving some patients IV fluids. It's very difficult. They have to be very, you know, but I've managed to convince our head of department that, oh, look, this might be a good idea, not because the IV fluids, but actually if you could then show that subcutaneous fluids achieve a similar effect. Subcutaneous fluids could be given to the patient by themselves at home. So you don't need a cannula, you don't need any of that, you don't need to worry about veins, you don't need a port, you just give the subcutaneous fluid and you just prescribe the saline. So if that works out, then that could be a game changer, to my mind. So he became very interested in that, and he said, look, you know, I'd be happy to do that. So that way I've managed to sneak a few patients in for IV fluids.
That sounds really positive, really good news. And it's so great to hear a doctor speaking up for the patients, because I can bet just about everybody listening in tonight has had the same experience as, well, certainly me, where you've tried and tried to have an intelligent conversation about what's happening to you. And because you don't fit in that little box in the computer say no. It's very frustrating for sick people who are losing their lives, like you said, you know, for 20 odd years. I can put my hands up to that. It's no good saying, well, you know, we have to you know, in so many years we'll have more knowledge.
Yeah.
Well, that person's life's over. You know, they've lost their career, they've lost their life.
Well,
So
this is exactly it. I mean, you know, you cannot build an evidence base if you're not going to try the meds out.
No.
so you're not going to, you can't say, oh, well, wait for the evidence. Well, who's going to try the meds out? You have to build clinical experience. You have to try the meds out. You have to demonstrate that actually in your clinical experience, they work. Then you design a properly funded, proper big study, and you demonstrate it. But again, you know, we simply cannot afford to wait for 20 years for someone to come and become interested in this. And also, I think that the boxes that were drawn by whoever diagnosed, whoever defined POTS, they were probably too narrow. You know, we are seeing these patients, whatever this condition is, whatever this condition is, there is a condition that is affecting so many people. And it falls on clinicians now to be able to be brave enough to say, look, I've seen as many as anyone else, and I believe this is the thing, and this is how I'm going to treat it. And, let's have a debate about that.
I agree with you totally. I do think, I mean, I'm not trying to put down your profession, but we seem to have a culture at the moment where if I don't know what's wrong with you, it must be all in your head. Yeah,
exactly. Absolutely.
That's not even scientific, is it? No. It isn't. And we have to move on, I think, from that culture, and the only way we will are with doctors like yourself. So it's so nice to hear you saying the things we need to hear. This is quite interesting. Can PoTS ever self-resolve?
I think I've found that a lot of patients will wax and wane. So there are lots of patients who come back to me and say, look, I've been really good for the last year. I'd like to come off the medications. And I say, sure, absolutely. I guess I haven't seen PoTS over that duration of time to tell you for sure whether there are people who just go away and never have it again. But what I do think is that people go through phases, and they can go through a 5-year phase of no symptoms, and then they'll get some symptoms, and then so it waxes and wanes. I think that genetic vulnerability never leaves you.
So when you say genetic vulnerability, like you said during your talk, do you think sometimes a viral infection, a bacterial infection can open you up to a disposition that you didn't even know you had? Absolutely.
I mean, it's very interesting. I mean, I hope they're not watching, but I had a family of 3, 3 people came, 3 ladies came into my clinic one day. The one was the patient, and she was accompanied by her mum, and she was also accompanied by her grandmom. So, and they all looked really angry and stern. And I was like, oh gosh, this is going to be a tough consultation. So I speak to the girl, and turns out she has PoTS. She has all the symptoms and everything else. And I talk to her, and I give her the medications, and I think to myself, oh gosh, that was a tough consult. I hope I'm not gonna see them for at least another month or so. But the next week they were all there again. And I said, oh God, they're going to be right. Something's wrong. What's going on? And it was the mother who said, actually, this time I'm here to see you because what you told my daughter last week completely resonated with how I have felt for the last 20 years. And can I try some of her medications? And in fact, I have taken some of her medications. I now feel better. And then the 3rd week, the grandmother came, and she said she had exactly the same thing. So we are beginning to see, and a lot, it's just, when did this happen, and how badly was that patient affected? How dramatic were their symptoms? Unfortunately, a lot of people have just continued to live with it because they've been told that's who you are, just live with it. And therefore they just accept it, right? I need my nap, and I can't get out of bed in such and such a day, and I can't really do that. And they accept that. And a lot of people have been branded as having IBS, and you've got fibromyalgia, and a very interesting group is a group who have been termed as having microvascular angina. You have angina, we don't know why, so you have microvascular angina. Really interesting. I've had a few people, and actually one of them is in this group today, who was diagnosed with microvascular angina and then turned out to have PoTS, and you start treating them for PoTS and they say, actually, I'm so much better now. So yeah. So again, it takes, people like me should be going to microvascular angina clinics and saying, let's do some research. Let's try these patients. Let's look for PoTS and start treating them.
Yeah, rather than just putting a label on somebody and saying, off you go, get on with it. That's the trouble, isn't it?
It's the trouble. And unfortunately, if you are then, you get put on all these other medications. And it becomes incredibly difficult to disentangle everything. So in some ways, the longer the list of diagnosis, the more meds you are, the less interested medical professionals are. It's too difficult to tease out. So they'll be like, oh yeah, it's one of those. Okay, just, try and, and that I think is unfortunate.
Which is pretty horrifying, isn't it? Because people do end up on a long list of medications. How on earth do you work out what's working, what's not working? And nobody can unpick it because often multiple doctors have been involved and they've all got their own idea. And yeah, I just think it's tragic in some cases.
And a visit with a GP is no more than 5 minutes these days, right?
Yeah.
So, and even then, you're only allowed to talk about one thing.
Yes.
So, how does a person who has actually been, served, all these meds for so many different conditions, actually, to my mind, one of the most important things for doctors to do is start taking off these meds.
Yeah, actually, I totally agree on that one. And so many, obviously, elderly people end up on a whole list of things, and nobody knows what's what. So I actually have that with my own mother at the moment, and I'm just like, so I just remove the book.
Patient-centered.
Doesn't make sense.
It's all protocol nowadays.
Yeah, I mean, no GPs have got a tough enough job as it is without trying to manage somebody with 20 different medications. So yeah, things need to change, but we have people like you who are really open-minded. It gives us hope. So I'll just do one more question because we've run quite a way over, and I always end up these seminars with this question because there are so many people who get stuck in a horrible place with chronic illness. It doesn't matter what you're talking about, whether it be PoTS, Lyme, ME, whatever. What would you say to somebody if a patient came to you with PoTS and they'd had such a long, drawn-out journey to find you? What would you say if they said to you, I've got no hope of getting better at all?
The first thing I would say is that I definitely think that there is hope of getting better. I think just feeling supported, feeling that there's someone who's willing to listen to you, I think being educated, being empowered, make a huge difference anyway.
Yeah.
So there is absolutely no doubt that. What I would say, though, is that trying to get medical help these days is a nightmare. Mm-hmm. And there are so many people in the middle who will have their own thoughts, who have their own way of doing things, and trying to just negotiate your way through and get to the person who has an interest is very difficult. And so I would encourage those people. So when you have Lyme, I personally think we know that there are specialists out there who have an interest in this condition. And if you can bypass all those other people, all those kind of people who are not interested in Lyme, but actually are interested in saying, oh, forget it, take some anti-anxiolytics or whatever, go and see that person directly. It's well worth the money, I think, because it beats 2 years of waiting around for someone to become interested in you. This way you actually meet the person who is interested in you and who can help you. And I truly believe that the job of a doctor is not to turn around and say, well, you don't fit in my box, so either you're mad or nothing can be done for you, but actually say, look, but I know someone who has an interest in this, and let me send you to that person.
Yeah, absolutely. Yeah.
Generally, yeah. So when I get a patient, I don't have expertise in joint hypermobility, but I try and send them to someone who has an interest. And so building a team of people around you who speak the same language is incredibly important. And that, I think, at this point in time, unfortunately, it falls on the patient to do. But it's worth it, I think.
Yeah. Thank you. That's really encouraging for people listening. Oh, it's sort of come over our time, but it's been really, really interesting. I'd just like to say to anybody who's registered today that we have been doing a series of these seminars on all different subjects. And if you follow our social media pages on Twitter, Instagram, Facebook, every few weeks we'll advertise a new seminar. And like I say, they're all different specialists, all different topics, and we found, we've had lots of really good feedback, and I think we'll get a lot of good feedback tonight. So I'd like to wind the session up by saying again, thank you. We really appreciate your time, and just thank you. And thank you on behalf of everybody who's attending it. If you have a quick flick in the chat box, you'll find lots of people saying thank you. So I'll save the chat box at the end and send it to you.
Oh, great. Yeah, of course. And I'd be more than happy to answer any other questions that people have after this.
That's wonderful. Thanks ever so much. And I'm going to close the meeting for everybody. And I'll be in touch, Dr. Gupta, but thank you. And thank you to everybody who's attended.
Thank you so much. Thank you, Jeff.
Good night.
Bye.